Hey guys, welcome back to Medical Mondays. Happy Monday and thank you for joining. So last week we talked about the possible complications and issues and revisional operations that may be needed after anti-reflux surgery. We talked about the testing, we talked about why you might need it. So today I want to focus on what those operations may entail. So what do you do if you have issues after these operations? Oftentimes, the first thing you start with is what's called a dilation. So we dilate the wrap or even a Linx, and usually you don't do that until you're about 6 weeks out to really give enough time for the swelling and post-operative changes to kind of calm down after surgery. If dilations and sometimes even steroids don't work, then you may need revisional surgery. You may need to have that operation readjusted or done completely over again to have a normal way of swallowing and eating. So let's begin with the Linx. So usually the issues with the Linx are that patients still have issues swallowing. If the Linx is too tight for your esophagus, then it has to be adjusted and it has to be taken out and a new one put in. Sometimes the Linx can erode. Only about 0.1% of patients, so 1 out of every 1,000 may get an erosion of the Linx. And if that's the case, the Linx has to come out. Most of the time, even after the Linx is taken out, enough changes have happened that you still will have an anti-reflux mechanism even with the Linx taken out with an erosion, or if it's too tight. How about fundoplication? So if you can't eat or swallow after a fundoplication, it depends on why that's happening. If your wrap is too tight or the hiatal hernia repair is too tight, sometimes you might get lucky and just be able to fix that with a dilation. You go in endoscopically, put in a balloon, and dilate things up to make it easier for the passage of food. Sometimes the wrap was done incorrectly. Either it's too tight and you can't fix it with the balloon dilation, or it's twisted and there's not a straight shot going into the stomach. Unfortunately, if you do suffer from this, these conditions require a whole new operation. The next issue I want to talk about is bloating. So some patients will have severe bloating that persists over time. Typically, those are patients who underwent a full wrap or fundoplication. The good news about that is that it's an easy fix. What we do is we convert the full wrap to a partial wrap, and that almost always will solve that problem. Finally, what if a patient has a more significant issue or injury, like an injury to the vagus nerve? If you injure the vagus nerve, your stomach doesn't empty as well as it used to. So you get what's called delayed gastric emptying or gastroparesis. Unfortunately, that's a much harder situation to fix. But the good news is that there are many different options of how you can fix that. Number one, sometimes Botox at the pylorus will relax things and allow food to pass through easier. If that doesn't last long term, you can do kind of a permanent Botox or mimic what a Botox would be with what's called a pyloroplasty, so cutting the muscle between the stomach and the intestine to allow the free passage of food. Finally, sometimes when all these other methods fail, you may need to convert the fundoplication or the Linx to a gastric bypass. The gastric bypass is probably the most effective operation we have today for gastroparesis or delayed gastric emptying. So again, before you can figure out what operation needs to be done, you have to do the testing to figure out what the problem is. So what do we do for these patients? After we've done all the testing, we figure out that it does look like things are too tight and things are not getting better with balloon dilation. My typical approach for these is to basically redo the entire thing. So it's a lengthy operation. Number one, we have to take everything back down and establish normal anatomy again. So once we establish normal anatomy, then I like to do the operation the way that I do it in the standard fashion, making sure things are not too tight, too loose, or twisted in a way that it's not supposed to be. And we have a very good success rate with revisional operations. Now, what if you've had a recurrence? So let's say somebody had surgery and they, a year or 3 years, 5 years later, have a recurrence of the hernia or the wrap has slipped. In those patients, we often like to do an additional operation. In addition to redoing everything, we do what's called a callus gastroplasty. So we published the second largest series of colic gastroplasties in the entire world with excellent results. So you also have to know why the patients had a recurrence, right? So sometimes the right operation wasn't done in the beginning. If you have a patient who's very overweight, so somebody with a BMI of like 35 or 50 pounds, 100 pounds over, and they came to you for reflux, that patient should have had a gastric bypass for anti-reflux. So if that patient comes in now with a recurrence, who's overweight, the best solution for that patient is probably going to be a redo hiatal hernia repair with a conversion of the fundoplication to a gastric bypass. So as you can see, there's a lot of different options and different roads that you can go down depending on why the patient's having issues. So number one, you have to start with doing all the tests to figure out what the issue is, and then coming up with the right solution for that patient depending on other factors like weight, or what the actual complication or side effect or issue is. So in summary, if you have had issues after anti-reflux surgery, it's not normal, and you should see an expert to, number one, figure out what the problem is, and number two, talk about the different options and solutions to it. On that note, I want to say thank you all for joining us again on our Medical Mondays. I hope you all have a wonderful week, and we'll see you again next week. Take care.